After a short break, today we are resuming our Wednesday academic series. And our sincere thanks to the organizing team of Child Neurocon 2022 for the excellent academic feast and hospitality. And we have made a few changes in our academic series, Wednesday academic series. Instead of the basic lecture series for the pediatricians, we have introduced the neuroradiology series, and the rest of the series will be continuing. So today we have our case discussion series, learning from little ones. The residents from CMC Vellore are presenting the cases today, and Dr. Sangeeta Yoganathan, Professor of Pediatric Neurology, CMC Vellore, will be the moderator for the session. Over to you, Sangeeta, for introducing the experts for today's case discussion, as well as the residents.
Good evening, everyone. We welcome you all for today's case discussion on encephalitis to think beyond infection. So we have two experts for this session today. It is my pleasure to introduce Dr. Maya Thomas, Professor and Head of Pediatric Neurology in the Department of Neurological Sciences, CMC Vellore. Madam is a clinician par excellence, and her field of interest are refractory epilepsy, neurometabolic disorders, and neuroinfection. And she has a lot of publications to her credit. And the second expert for today's session is Dr. Ramesh Konangi. He is a consultant pediatric neurologist at Rainbow Children's Hospital, Hyderabad. And he has several publications in national, international index journals, and he has authored several book chapters. His field of interest are neonatal neurology, stroke, neuromuscular disorders, epilepsy, and neurodevelopmental disorders. Today we have two presenters. One is Dr. Narmadam. She's a final year DM resident in our pediatric neurology unit. And the second presenter is Dr. Lenka Sushma. She is a second year DM resident in pediatric neurology unit. Over to the presenters. Narmadam.
Good evening, everyone. Today is my first day.
Your voice is not clearly audible, Sushma.
Am I audible, Tanya?
Yeah. Now it is audible. Yeah.
Yeah. Today is my first day. 3-year 10-month-old boy. The resident of Patisatu district, Tamil Nadu. He is the second born non-confined parent. Presented to us with chief complaint of sudden onset of losing of left eyelid, followed by nasal regurgitation.
You are not audible, actually. I am unable to hear, I think.
See, your voice is fluctuating. Sometimes it's heard well and sometimes it's very low.
Can you increase the volume of your laptop device?
Can you use a headphone? Use a headphone, it will be uniform.
Yes,
or speak near the mic of the laptop.
Can remove the ear plug and then try speaking directly to the.
Sushma, there is a headset available over there. You can use that.
Ma'am, is it audible now?
Yeah, it is better.
So today, our first case of a child, here 10-month-old boy, resident of Tirupattur district, Tamil Nadu, who is second born to non-consanguineous parents. He presented to us with chief complaints of sudden onset of drooping of left eyelid and nasal regurgitation of feet, followed by respiratory distress and distress sensorium for 1 day. So he was well. Then on awakening at 6 a.m., he was noted to have low-grade fever with cold cough, and also mother noticed that he had left eye drooping. But he was able to communicate, interact with parents, and was able to walk around. At around 10 a.m., when given a glass of water, he had an episode of non-projectile vomiting, and also he had regurgitation of water. nasal regurgitation. And also mother noticed that there's some change in his voice with nasal twang of voice. So gradually over next 4 hours, his sensorium gradually worsened and he had hypersomnolence and lethargy. And there was also history of difficulty in getting up from supine position, rolling over bed, raising of hands overhead, and also he had difficulty in lifting his legs off the couch. Mother also noticed that the child was extremely floppy. So they had immediately taken to a local hospital, and he was admitted there, and the child on IV fluids. And over next 4 hours, his sensorium worsened, and he had breathing difficulty, and also had developed one episode of seizure in the form of upward gaze with lapse of awareness that lasted for 2 minutes. So he was referred to CMC in pediatric casualty since because of his low sensorium and hypoxemia, he was intubated and shifted to pediatric ICU. Otherwise, he had no difficulty in with any vision symptoms. There was no squint noted. He had no deviation of angle of mouth. There were no features suggestive of extrapyramidal involvement, cerebellar involvement. There were no autonomic disturbances, and there were no bowel bladder disturbances. And he had no exposure to toxins prior to the event, and there was no history of trauma. And he had not received any vaccinations recently prior to the event, and there was no history of any animal bite, or he had no history of diarrheal illness or respiratory infection prior to the event. And also there was no history of sore throat or neck swelling, or he had not consumed any honey or canned food prior to the event. There were no COVID infected people in and around the house, and no one in the family members was infected with COVID. So his antenatal and perinatal period was unusual. He was developmentally normal for his age and not placed in school yet. He was immunized up to age according to the national immunization schedule. There were no family history of neuropsychiatric illness or epilepsy in family. So based on the summarizing the clinical history, is a 3-year, 10-month-old boy with no antenatal perinatal risk factors, developmentally normal, presented with acute history of rapidly progressing descending weakness, started with ocular involvement in the form of left ptosis, followed by bulbar and respiratory muscle involvement. There's also a history of fever, seizure, and altered sensorium with no other neuraxis involvement. So based on the history, the localization, we would localize to brainstem or polyradicular neuropathy or neuromuscular junction because of the involvement of facial muscles, extraocular muscles, bulbar and respiratory muscles. And the etiology under consideration were viral rhombencephalomyelitis, parainfectious diadem, Bickerstaff brainstem encephalitis, neurotoxic snake envenomation, even though there was no history of snake bite. Then diphtheric polyneuritis, and botulism was also considered based on the pattern of weakness. So on examination,
Dr. Ramesh, yeah, just hold on, Sushma. Dr. Ramesh, would you like to ask? You have any questions with regard to the history?
Yeah. Can you go back to the previous slide? Okay. So based on your history and
localization,
are you able to explain everything with these localizations?
Based on the
Caesars?
brainstem, because he had altered sensorium with ocular and bulbar involvement, and even neuromuscular, and the seizure could be a part of hypoxemia secondary to altered sensorium, and polyradicular neuropathy again because he had involvement of cranial nerves, C4-6, I mean third cranial nerve in the form of ptosis, then bulbar and respiratory muscle involvement.
Okay. So why do you say only third nerve palsy? Can ptosis be caused by something else? See, if you have to localize to the brainstem, which part of the brainstem?
Ptosis again in the brainstem, midbrain, because third nerve nucleus is there. And
And do you have nasal regurgitation of feet?
Yeah, historically, both midbrain and then medulla.
So it has to be very extensive lesion, starting from midbrain to medulla oblongata, isn't it? To explain so many things. So is there any, can it be just single focus in the brainstem, which can explain these cranial nerve findings and encephalopathy? Not everything, but at least the ptosis and encephalopathy and nasal regurgitation.
Infection.
Oh, no. What is the what could be the other? Sorry, ma'am. What else can cause ptosis other than third nerve palsy?
Not able to hear. I'm just.
Sympathetic palsy, right? Even sympathetic palsy can affect, can cause partial ptosis, right? So it can be just if it's in the brainstem, just the medulla or lower brainstem involvement can alone explain so many things: nasal regurgitation, ptosis, respiratory failure, correct? Because central respiratory failure, that's what it looks like, right? And respiratory distress with the clear lungs, very rapidly progressing encephalopathy. Okay, so can you put your differential based on history in the prioritize them out of these 6 differentials? Which will be your topmost differential?
Again, viral encephalitis brainstem involvement, which can explain most of the symptoms.
Okay, viral rhombencephalomyelitis. Okay.
And Victor encephalitis,
Okay.
which can explain the ptosis and ankylosing.
So epidemiologically, which are the commonest out of these 6?
Viral rhombencephalus.
Okay.
Antiviral.
So what will be the second one after infections?
Adam.
So Adam, this presentation is extremely uncommon, isn't it? Progressing so rapidly over one day, isn't it?
Yes.
Generally, it is much more slower evolution. I think the snake envenomation is much more common epidemiologically, still in many parts of our country, correct?
Yes.
So is there anything which is not explained by snake envenomation?
Fever, we had multiple local fever and
Okay, so I think viral infections, then snake envenomation, then Bickerstaff brainstem encephalitis, and then other differentials would be logical, looking at the epidemiology and the localizations that you have. Diphtheritic polyneuritis, why will it have encephalopathy? It won't have encephalopathy, isn't it? And it's so rapid, isn't it? Same with botulism. Why will botulism cause encephalopathy? It's a neuromuscular junction toxin. Okay. Dr. Maya, anything else you want to add?
Yeah, this I think one other reason for the seizure and the altered sensorium was this rapidly progressive respiratory muscle weakness, due to which there was an element of hypoxemia and some amount of hypoxic encephalopathy. So that is when you have a rapidly progressive ascending or descending weakness, that's another reason where you can have hypoxic encephalopathy and seizures. So that could be the other explanation for when you're saying the other differentials of, like a diphtheritic polyneuropathy. But again, rapidly progressing. Again, neurotoxic snake envenomation also, when you have a very rapidly progressing, giving rise to respiratory paralysis, then that is another explanation that you could think of.
Yeah. Anything else which can evolve over hours like this? Any other group of disorders? Any vascular conditions? Any ischemic strokes involving the posterior circulation predominantly, right? So anything which involve brainstem. Okay.
Yeah, absolutely, because brainstem strokes are known to evolve over, several hours, posterior circulation stroke. So definitely that also could be a potential differential. Yes. Somebody, I think, asked that question, came up in the chat box.
Yeah. Right.
Okay, Sushma, you can proceed.
On examination, the child's GCS was 8T/15, and his vitals were stable on SIMD mode of ventilation, and his weight, height, and circumference were between -2 to -4. And general examination, there was no vital histopathology, and throat examination did not reveal any membranous tonsils, and there was no evidence of snake bite, dog bite, or HF. So neurological examination, cranial examination revealed pupils were equal and reactive, and this was normal. But there was restricted eye movement in all the directions, and there was bilateral ptosis. For the corneal reflex present, there was a bifacial weakness with weak gag and pulling of secretions. Most of some examination revealed normal bulk, there's both axial and appendicular hematuria, and there's reduced cover in all four limbs, proximal more than distal. In upper limbs, proximal cover was around 1/5, and the distal was and at elbow and wrist it was 2/5, and in lower limbs it was at around at fifth it was 1/5, and knee and ankle was 2/5. The deep finger reflexes were not visible in all the four limbs, and the phantom was dilated, etc. There were no cellular signs, there were no signs of meningeal irritation, and his current examination is normal. And other system examination also is really available. So this is the child and so you can see that the bilateral ptosis and bleeding difficulty.
So can you be sure about the GCS of 3/5 in this child? What is the
80/5, 80 and 5, sir.
GCS? Yeah. Okay. Sorry. What is the GCS you said?
83 VT and 5, sir.
Okay. Okay. E3 VT M5. Okay. M5.
Yes, sir.
Okay, but all your muscles are muscle power is 1/5, 2/5. Okay. How did you get M5?
Actually, to increase this, trying to localize the pain.
Okay. Okay, fine.
Summarizing the case. Summarizing the case with a child with premorbidly well child with acute onset of symmetric descending weakness involving ocular muscles, that is external ophthalmoplegia, facial, bulbar, and respiratory involvement with altered sensorium and a brief episode of seizure. And he also had classic bradypulses, proximal more than distal, with areflexia. So based on the clinical findings, the localization would again pertain to brainstem, peripheral nerves, neuromuscular junction, and the possibilities would be the same in the order of viral encephalomyelitis being the first most possibility that's considered, followed by parainfectious addend, because brainstem encephalitis. And diphtheric polyneuritis, both reasons are also considered. Myasthenia with crisis was also considered because of the pattern of involvement of extraocular and bulbar respiratory involvement.
After examination, would you like to rearrange your differentials with reasons?
Yes, again, so extra points in examination were he had extraocular external ophthalmoplegia, was a classic cardiac dyslexia. Again, viral encephalomyelitis can explain the bulbar and respiratory involvement and also quadriparesis. If
So is it symmetrical weakness?
it's symmetrical weakness,
Right.
which is less likely in myelitis condition. For symmetric weakness.
So it has to be extensive myelopathy to cause such a severe symmetric flaccid weakness of all the limbs, isn't it? But without any bowel and bladder involvement. Although bladder is very difficult to comment in such a short period. Generally, infective conditions tend to be more patchy, isn't it, when they cause myelopathy? Okay. Other differentials?
Because of Wilson encephalitis can have this Wilson involvement and also petrogenic involvement. That will extend symmetric weakness to the
Sushma, your voice is kind of breaking. So
Am I audible now, ma'am?
yeah. Just keep
Better.
it in one position, the mic.
So both brainstem involvement and symmetric weakness, like central nerve involvement, explained by because of brainstem encephalitis, where there is both CNS and peripheral nervous system involvement, and then again. Parainfectious Adam will have brainstem involvement, but again, symmetric weakness with areflexia is without bowel bladder symptoms.
See, ADEM is unless you have some antibody positivity, it is mostly it is an exclusion diagnosis post imaging, isn't it? Clinically, with such a atypical presentation, it's very unusual to keep ADM as a differential with the progression over hours, right? Very rapid progression. So Bickerstaff brainstem encephalitis will probably explain most of the findings, right? Including rapidly progressing encephalopathy, respiratory failure, ophthalmoplegia, facial palsy, right? And flaccid quadriparesis. So everything can be explained with Bickerstaff encephalitis. Is that right? Is that right? So whatever explains everything, including the clinical course, that should be your topmost differential.
Yes.
Okay. So what is the next differential?
Sushma, where are you? We can't hear you.
Yeah, both of you can answer.
Ma'am, am I audible, ma'am?
Yeah. Did you hear Dr. Ramesh's questions?
Yes, ma'am. So after Bickerstaff encephalitis, the next possibility.
So can it be myasthenic crisis? The first time myasthenia presenting with a crisis. Can it explain everything?
Bulbar and respiratory involvement and classic quadriparesis.
Is there anything which can't be explained with myasthenia? See, even after ventilation, also child is still encephalopathic. That's unusual with any neuromuscular weakness causing encephalopathy. Generally, they should improve quickly in terms of encephalopathy, right? Once the ventilation is taken care.
Okay, Sushma, proceed.
Yeah, go on.
considering our differential and viral encephalomyelitis, again the big points in favor were started with fever, encephalopathy, one episode of seizure, multiple cranial palsy, and he also had hypotonia with areflexia. But again, the extensive symmetric in placid quadricultus with areflexia would not be fully explained by viral encephalomyelitis. Then the next differential we considered was parainfectious Adam, which again points in favor were he presented with fever and encephalopathy seizure along with cranial multiple cranial involvement and hypotonia with areflexia. But again, it was a symmetric involvement and there was no bowel bladder involvement. So these were the points against Adam. Then because of brainstem encephalitis, most of the clinical symptoms and signs could be explained by because of encephalitis. He had altered sensorium, it's an ophthalmopathy, classic quadricultus with areflexia, and there was no, but he did not present with ataxia. And then for diphtheric polyneuritis, the pattern of involvement starting with ptosis and bulbar involvement and reticulation involvement were in favor of diphtheric polyneuritis, although historically we did not have any sore throat or neck swelling. Then myasthenia with crisis, again the involvement of facial ocular muscles with respiratory muscles and classic quadricultus would be in favor of myasthenia with crisis. But he had encephalopathy and there was no history of fatigability in the past, and he had complete areflexia, which is less commonly seen in neuromuscular junction disorders. So considering these differentials, we had worked up this
Dr. Narmada, why did you take out snake envenomation from this list? Any reason? Why did you take out snake envenomation?
Historically, and also our examination.
Because everything can be explained with snake envenomation also, neurotoxic snake envenomation, correct? Encephalopathy, seizures, neuromuscular weakness. Yeah.
Yeah, definitely. I think we should, snake envenomation also should have been on the list. And somebody has already also mentioned rabies. I think that's already mentioned in the first differential.
Correct.
Viral encephalomyelitis, enterovirus, and rabies, definitely.
Many times you will not get history of snake bite and you can't find the bite marks also. Okay, go on.
Considering these differentials, we worked up his routine blood investigations were normal, and the diphtheria throat swab and PCR was negative. Although his COVID RT-PCR was negative, his COVID antibodies were positive, and AFP surveillance was also done, and his sample was sent for AFP surveillance. And because he had classic quadricultus with areflexia, nerve connection study was done, which showed reduced Cmax in bilateral facial nerves, and Cmax were also reduced in both upper and lower limbs with normal conduction velocities, and there were no conduction blocks, and snaps were normal, and H2 and net latencies were normal. So nerve conduction study was suggestive of a motor axonopathy. So imaging was done in this child, MRI brain with contrast, which was normal, and EEG showed bihemispheric flow wave disturbance. So we went ahead with CSF analysis, which showed albumin cytological dissociation with a cell count of 5 cells and elevated proteins. Rest of the workup, including CSF culture, viral multiplex PCR, enterovirus PCR, and the biofilm array were all negative.
Sushma, there is a question as to was RNS done? Repetitive nerve stimulation.
RNS is also done, that is negative. That's not negative.
There was no evidence of any decremental response. Okay.
Didn't do the spine imaging? Spine MRI?
Spine,
Okay, because that was your topmost differential, viral ramen myelopathy, right? Okay, and what day this CSF was done? What day of onset?
Done on day 6 of Indian.
Day 6. Okay, fine. Okay, go on. I think you already gave the answer. Hmm.
So we've sent serum anti-angular antibody, which is strongly positive for IgG anti-GQ1B antibodies. So this is a child who presented with acute encephalopathy, extended ophthalmopathy, bulbar and respiratory muscle involvement, classic quadriceps with aorexia. So he was diagnosed with Vicker's brainstem encephalitis. We treated him with respiratory support, nutritional care, intravenous antibiotics, and specific therapy. He received intravenous immunoglobulin 2 grams per kg over 5 days. And gradually we could wean him off ventilation over over 20 days and given him physiotherapy. So at discharge, he was awake, alert. Bulbar weakness was still persistent, so he was discharged on nasogastric tube. His ptosis and ophthalmopathy was improved significantly, and even the facial weakness. His limb power also has improved, and he was able to walk with support. Deep renal reflexes were absent. His modified tube score was 3. This was videos after discharge. In the first video, his stroke significantly improved, and even the extraocular movements. And this is the video showing walking with one hand out. He was able to walk with minimal.
This is a video taken about 1 month after discharge.
Yes, ma'am.
Yeah, he still has some bulbar weakness. He still has some amount of distal weakness, isn't it? Some bilateral foot drop is seen. Okay, proceed.
So brief discussion on Vicker's brainstem encephalitis. So the diagnostic criteria for encephalitis include one major criteria and 6 minor criteria, of which at least 2 required to diagnose possible encephalitis. 2 are more probably confirmed encephalitis. So the major criteria includes patient presenting with altered sensorium for more than 24 hours with no alternative cause. And the minor criteria include fever more than or equal to 38 degrees centigrade at presentation or immediately after presentation, new onset seizures, new onset focal neurological deficits, CSF analysis showing elevated cell count, more than 5 cells per mm3, abnormal MR imaging suggestive of encephalitis, and abnormal EEG that is consistent with encephalitis. So the WHO definition of acute encephalitis syndrome is acute onset of fever and change in altered sensorium with or without new onset seizure in a person of any age at any time of the year. So acute encephalitis syndrome has both infectious and non-infectious etiology. Infectious etiology include viral, various DNA, RNA viruses, bacterial, fungal, and parasitic infections, whereas non-infectious include immune-mediated encephalitis, ADEM, and vasculitis and collagen vascular diseases. So, Vicker's encephalitis is classified as non-infectious immune-mediated encephalitis. Vicker's encephalitis is an immune-mediated disorder that involves brainstem and peripheral nervous system. It is classically described by a triad of ataxia, encephalopathy, and ophthalmoplegia. So usually there will be an antecedent respiratory or gastrointestinal infection. Most common organisms reported were mycoplasma, Haemophilus influenza, and Campylobacter jejuni. So there was a because of molecular mimicry between the GQ1B ganglioside and lipo-oligosaccharides of these organisms, there is autoimmune mediated injury which affects both the central nervous system and peripheral nervous system. So in the spectrum, to one end where predominantly peripheral nervous system is affected is the Miller-Fisher variant, which presents with ataxia, ophthalmoparasis, and areflexia. And to the when CNS is involved because of because these antibodies cross the blood-brain barrier and attack the reticular formation, which results in impaired consciousness. That is that's more in favor of BHF prevention. So anti-GQ1B syndromes is a wide spectrum which involves multiple disorders, predominantly classified based on predominantly peripheral nervous system involvement or central nervous system involvement. So if predominant central nervous system involvement is there, biggest peripheral nervous system is to be considered, and predominant peripheral nervous system with ataxia, areflexia, ophthalmoplegia, then Miller-Fisher variant is considered. However, there were variants with only isolated ophthalmoplegia, isolated ptosis for mydriasis, or with isolated ataxia. And CNS involvement with classic quadripartite and areflexia, then because of encephalitis with GBS overlap can be considered. So, comparison of most common anti-GQ1B syndromes. Bickerstaff and Miller-Fisher variant is more common in much more common in Southeast Asia, and GBS is common worldwide. The diagnostic criteria includes ophthalmoparasis and ataxia in both Bickerstaff and Miller-Fisher. The only difference is involvement of brainstem and altered sensorium is in favor of Bickerstaff encephalitis, whereas without involvement of altered sensor, without involvement of brainstem, more in favor of Miller-Fisher syndrome. And laboratory findings by CSF has albumin-psychological dissociation in all the three syndromes with mild CSF pleocytosis. Anti-GQ1B antibody can be positive in all the three syndromes, although the positivity is up to only up to 2/3 of the cases. MRI findings in Miller-Fisher variant in GBS predominantly with the peripheral nerve involvement. So MRI brain would be normal. GBS we find this chorda equina enhancement in MRI spine imaging. Then Bickerstaff encephalitis, MRI majority would be normal, but there are various case reports where brainstem signal changes been reported. The criteria again, Bickerstaff encephalitis has altered sensorium along with ophthalmoparasis and ataxia, whereas in Bickerstaff encephalitis GBS overlap, along with the three symptoms, there will be fractured quadripartite. This is one of the systematic reviews which was published in the Journal of Neurology in 2018, where the 52 children under the age of 50 years were studied, and they have noted that most of the children, up to 90% of the children, had preceding illness, either URI or gastroenteritis, and the commonest presentations noted was again classic quadripartite with areflexia and bulbar palsy, even to the children with Bickerstaff encephalitis, although 50% of the children have presented with altered sensorium. The investigations, the main investigations for diagnosis include CSF analysis, which will show albumin-psychological dissociation, and imaging. MRI would be normal in majority, although there are MRI brain might show changes in T2 flare images in brainstem and diffuse ganglia. EEG shows bihemispheric global disturbance. Again, EMG, when done, axonopathy pattern is much more commonly seen than dynamic pattern. And in 2/3 of the cases, serum IgG anti-GQ1B antibodies will be positive. So again, this systematic review in which they have noted that abnormal EEG was up to 2/3 of the cases, However, the anti-GQ1B positivity was also in around two-thirds cases. The predominant case of changes noted was again albumin-pathological dissociation and clear cytopenia. So although the presentation is with acid sensorium and the overall the picture had a good prognosis, with the recovery usually starting within 4 to 6 weeks after starting on the treatment. And the main modalities of treatment include intravenous immunotherapy and plasma pheresis. So this again the same review quoting that the common treatment modalities considered was IVIG, plasma pheresis, and few cases have also considered the steroids along with IVIG. So goes to a child with encephalitis presentation. So after the history and clinical examination, imaging and CSF analysis along with EEG would give further proof. If CSF analysis shows is suggestive of infective etiology along with the imaging findings with septal enhancement or involve typical infectious changes, then treat with appropriate antibiotics and antivirals. If the imaging and the CSF is negative for infection, then based on the predominant symptomatology, if the predominant symptoms again in an encephalitic child presenting with acute psychiatric symptoms and seizures, extrapyramidal symptoms, autoimmune encephalitis has to be considered and worked up accordingly. If a child with altered sensorium presenting with ophthalmoplegia, ataxia, flaccid quadriplegia, and areflexia, then a nerve connection has to be done, and also anti-GQ1B antibody, if feasible, has to be done, which gives additional diagnostic clue for the diagnosis of Bicester brain cell encephalitis. So, Bicester encephalitis is a rare condition that has to be suspected in children who present with acute onset altered sensorium ataxia, ophthalmoplegia. And again, this Miller-Fisher GBS Bicester is a part of a same spectrum, that is anti-GQ1B autoimmune mediated disorders with predominant CSF involvement. It's more towards Bicester encephalitis, and predominant peripheral nerve involvement. It's again more towards Miller-Fisher variant. There's a good recovery with indigenous immunoglobulins in plasma pheresis. And the prognosis for simple Bicester encephalitis is much more better when compared to a overlap syndrome with overlap with Miller-Fisher or overlap with GBS.
Thank you, Sushma. There was a question as to what was the NCS diagnosis. So what is your answer to that? The nerve conduction study showed reduced CMAPs, isn't it?
Nerve conduction study showed the motor action.
Yeah, it just showed reduced CMAPs, both motor and sensory, or only motor?
Reduced CMAPs in both upper and lower limbs with normal conduction.
Was it axonal or demyelinating?
Axonal.
So it was like an axonal, and F latencies were prolonged.
F latencies were normal, H reflex was also normal.
Yeah. So that was more like a motor axonal neuropathy, isn't it? Polyneuropathy.
I think well presented. I think management wise, it's very difficult case to manage because all your initial investigations will come normal. Probably NCS, you may see very non-specific changes very early. Maybe by end of first week, you might see these changes. MRI, CSF, even unless you do late in the course, it may not show any changes at all. So that way, it's very difficult to manage in the acute period. Unless you consider the diagnosis, you will just miss it out, or you will delay the treatment. Second thing is still, I think in India, we should still consider snake envenomation, because unless you treat it on day one, the recovery tends to get delayed if it's a neurotoxic snake poisoning. So many times we do end up treating them. So is there a way you can differentiate Bicasta brainstem encephalitis and snake envenomation early in the course? Say day one, you did MRI, came normal, NCS comes normal, CSF also comes normal. So is there any way you can differentiate between the two? Because treatment is different. You will either give anti-snake venom or you will give IVIG. Root conduction day one may come normal even in Bicasta brainstem encephalitis, or may show some non-specific reductions in CMAP, or latencies might be prolonged a little, but yeah. So is there any role of doing evoked potentials to say that this is brainstem involvement? I think some of the adult series, they have shown evoked potential through the brainstem, that is BERA, SSCPs. Alterations in those may suggest the localization to brainstem than snake envenomation, which has a more diffuse cerebral involvement in terms of toxic effects. So that is one thing. So did you, okay, I think the antibodies must have taken some time, right? What day did you get the antibody report?
Antibody reporting usually takes around 3 to 4 days.
3 to 4 days, okay.
Yes, Dr. Ramesh, definitely this was a challenging case and was being managed under the general pediatrics as acute encephalitis. And, it was when the child was not responding to treatment that when we were involved, and further tests, revealed the diagnosis. So definitely there was a slight delay in arriving at the diagnosis. Yeah, well presented, Sushma. Thank you very much. I think we'll move on to the next case because we are running short of time. Sangeeta, any further questions in the chat box?
Yeah, there was one question whether can we conclude the diagnosis on this child as Bicasta brainstem encephalitis and GBS overlap based on the clinical and NCS finding? That was one query.
Yeah, that is what I think she has a slide for that, isn't it? Where you have that Venn diagram which shows GBS, MFS, and brainstem Bicasta encephalitis.
Yeah.
Yeah, and all of them have GQ1B antibody positivity.
Yes.
Any other questions? That's it.
They have asked Miller-Fisher syndrome and Bicasta brainstem encephalitis. Both you will have GQ and antibody positive. Comments, please. How to differentiate, because both will have a anti-GQ and B antibody positive. So how will you differentiate? So she has already projected a slide table for that. It's not based on the antibody testing alone. It's based on the constellation of the clinical symptoms.
Yeah, the evolution is very different between the two. One is very rapidly progressive, other one is more slowly evolving. And encephalopathy is not usually featured with MFS.
I think there are no more questions.
We'll move on to the next case then.
Yes,
Dr. Narmadam.
Yes, ma'am. My screen visible, ma'am?
Yes, Narmadam.
Yeah, good evening, everyone. So today I'll be presenting the second case for this evening. So this is for female child, Miss H, 13 year and 6
think you
months.
need
Your,
to,
your voice is not that audible.
I think, sit closer to the screen.
So this is Miss H, a 13 year and 6 month old female girl who was, female child who was first born to non-consanguineous parents hailing from Gudiyatham, which is in Vellore. And she came with the chief complaints of fever for 3 days since 15th of January 2022 and altered sensorium since 20th of January 2022. So this is her family pedigree. So she's the firstborn, and apart from an abortion, there are no other risk factors. And her antenatal period, mother's antenatal period was uneventful, and baby was born with an uneventful perinatal history. And she had attained all milestones age appropriately, and she was studying in 8th class with good scholastic performance, and she was fully independent in activities of daily living. She had attained menarche at 12 years of age with regular cycles, so there were no vision or hearing concerns. So coming to the history of presenting illness, so on 15th of January 2022, she developed high-grade fever for 3 days without any localizing signs, which subsided with oral paracetamol. So after 3 days of fever, on 20th of January 2022, she developed excessive drowsiness, decreased word output, and decreased interaction with the parents. She also developed headache over the bifrontal region. There was also a history of pooling of secretions with occasional cough while taking food. And on the next day, 21st of January 2022, she developed her sensorium worsened further, and she was not responding to simple commands also. Apart from that, during the course of this event, there was no history of any restriction of eye movements, diplopia, facial asymmetry or hearing disturbances, stiffness of limbs, unsteadiness while walking, tremulousness on reaching for objects, or jerky eye movements. There was no history of bowel or bladder disturbances. Prior to this, there was no history of recurrent fever, joint pain, joint swelling, oral, nasal or genital ulcers, dryness of eyes or mouth, redness of eyes, hair loss, skin rash or photosensitivity. And there was no history to suggest recurrent infections such as ear discharge, loose screws, impetiginous skin lesions, recurrent lower respiratory tract infections, nor there was a recent contact with COVID. There was no family history of neuropsychiatric or encephalopathic illness. The past history, the child had a significant past history. At the age of 3.5 years, she had fever for 4 days, and on day 5 of illness, she had altered sensorium and multiple episodes of generalized tonic seizures. So on review of the past records, during this time, the child was admitted in CMC and she was mechanically ventilated for 5 days. So on review of the past records, she was found to have a GCS of E2, VT, and M3. Her vitals were stable, pupils were equal and reacting, dorsal reflex was present, off reflex was present. She had episodes of decorticate posturing and bilateral plantars were extensor, and there were no signs of meningeal irritation. So during that particular admission, routine blood investigations were normal, and infectious etiology, including urine, blood, were negative. Malarial parasite and wheal flix were negative, and the CSF examination revealed one cell with a glucose of 66 mg per deciliter, protein of 33 mg per deciliter, and a CSF culture revealed no growth, and viral multiplex PCR was negative. So at that point of time, at 3.5 years of age, this was the MRI brain that was taken. The T2 axial section of the brain, which showed like patchy hyperintensities in the pons, and again we are able to see on both sides we are able to see hyperintensities, and also in the dorsal pons, and in the midbrain and the periaqueductal region, and in the bilateral cerebral peduncles we are able to see hyperintensities and bilateral asymmetric hyperintensities in the thalami. And also in the diffusion weighted imaging, we can see some diffusion restriction in both sides of the pons. And there is some central area of ADC hypointensity with a surrounding hyper intensity suggestive of a cytotoxic and vasogenic component. Also in the thalamic lesions, we are able to see some vasogenic edema. And this is the post-contrast T1 imaging, which shows some amount of contrast enhancement in the thalamic lesion. And this was the SWI during that time. There is no significant areas of blooming. Some speck of blooming is seen in the pons. And this is the spine screening done at that time, which apart from the brainstem lesions, we are not seeing any lesions on the spinal column. So at 3.5 years, she was managed with empirical antibiotics and antivirals, and anti-seizure medication phenytoin was given, and provisional diagnosis of acute disseminated encephalomyelitis was made, and she was managed with intravenous methylprednisolone, pulse dose of 30 mg per kg per dose for 5 days, followed by tapering oral steroids over 1 month. At discharge, she had a modified Rankin score of 4. And she could interact with parents, take oral feeds, but was unable to sit or stand without support. And over the next 2 weeks, she completely recovered to the pre-morbid state, except for a residual divergence of the left eye after recovering from the illness, but there was no history of any diplopia or restriction of eye movement. So this was at 3.5 years of age. And the current admission, the examination findings was that when she presented with the fever, altered sensorium and seizures, she was intubated and mechanically ventilated in view of low sensorium, and she was shifted to the pediatric intensive care unit. Her GCS was 2T/15 and her vitals were stable, and her anthropometry wise she was well built. And there was no history of there was no facial dysmorphism, neurocutaneous markers or lymphadenopathy. There was no evidence to suggest infection such as scar or recent trauma or IV drug abuse, and her TANF stage was 4. And bilateral pupils were pinpoint and sluggishly reacting, and the fundus was normal. Doll's eye movement was absent, and the left diverging squint was present, and there was no ptosis at that point of time in which was ventilated. And cough reflex was present on suctioning, and hypotonia with hyporeflexia was there. Plantars were bilateral, there was no response. Spine and cranium were normal. The examination of other systems revealed no significant abnormality. So summarizing, this is a 13.5-year-old girl who was first born to non-consanguineous parents with a history of recurrent episodes of encephalitic illness, one at 3.5 years of age and again at 13.5 years of age. And during 13.5 years of age, there were bulbar symptoms such as choking while taking food. And there was the encephalitic illness at 3.5 years of age seemed responsive to steroid therapy. So in the current admission, she was admitted with 2T/15 GCS with hypotonia, hyporeflexia, and absent dorsal eye with normal fundus examination and no meningeal signs. So based on this history and examination, because of the altered sensorium and encephalopathy, the localization would be to the cortex. And because of the presence of bulbar symptoms, when she was still having a preserved sensorium, when she was choking over food, there would be a localization to the lower cranial nerve in the brain. So the etiological possibilities considered were ADEM, like a recurrent multiphasic ADEM, and neuromyelitis optica spectrum disorder was considered. Neurosarcoid, recurrent meningitis, systemic vasculitis with CNS involvement such as SLE or Behçet syndrome were considered among the differentials.
Go ahead, Narmada, because I think we are running short of time. So you please go ahead. Yeah.
So at this current admission, again MRI brain and spine screening was done. So this reveals this is the T2 axial MRI brain, which reveals hyperintensities which are patchy in the dorsal medulla and also in the anterior medulla, and also it is diffusely involving the pons in a heterogeneous manner, and also in the periaqueductal region and in the bilateral cerebral peduncles in the midbrain, we are able to see hyperintensities. And there is swollen thalamus with bilateral with hyperintensities, which is near symmetric, and also there is involvement of both posterior limb of the internal capsule. There are no cortical lesions, and these areas of T2 hyperintensity are appearing hypointense on T1. And on post-contrast imaging, we are able to see patchy contrast enhancement in the pons and in the thalamic lesion. On diffusion-weighted imaging, there was areas of diffusion restriction in the ventral pons and also in the thalamus, as we can note here. And in the thalamus, here if we see that the speck of hyperintensity is surrounded by a hypo-intensity and then again a hypo-intensity, which is typically described in one of the disorders which will be discussed. And also on the SWI imaging, we are able to see blooming in the ventral pons and also on the thalamic lesion. So the spine screening revealed, in addition to the brainstem changes, there is hyperintensity and swollen cord extending from the C3 up to the C6 cervical vertebrae. And the MRS was showing up on placing the voxel in the thalamus, it was showing a lactate field. So at this point of time, investigations were done, and the routine blood investigations, including a complete hemogram, LFT, creatinine, and CPK were normal. And CSF analysis revealed 35 cells, which were predominantly lymphocytic, with a protein of 32 and glucose of 74, and CSF lactate was normal. And her viral infectious workup, including viral PCR, bacterial culture, biofilm array, latex agglutination, MJIT, Gene Expert PCR, Cytosine Study, OCB, Autoimmune Encephalitis Panel, and Japanese Encephalitis IFA were all negative. And infectious workup for Rickettsia, Salmonella, and blood culture was normal. And blood-borne virus strain, NMOSD strain, HLA-B51 onconeural antibody panel was negative. And vasculitis workup was done, which was non-contributory except for a mild positivity in lupus anticoagulant and low complement levels. IEM screening was done, which was non-contributory. And nerve conduction study revealed a mild motor actinopathy in lower limbs and right facial neuropathy. And because of the hospital protocol, RT-PCR was done on, so it was positive with a CT value of 26, which is suggestive of COVID-19 infection. So coming to the management, she was managed in the KIC with neuroprotective measures, anti-seizure medications, and empirical antibiotics. Intravenous immunoglobulin was administered at 2 grams per kg and over 5 days, and methylprednisolone was given at 30 mg per kg for 5 days, followed by oral steroids. Her sensorium gradually improved, and while recovery, we noted that child was in a transient locked-in state, and she could communicate by blinking in response to commands. And initially, ophthalmoparasis was noted, and while recovery, there was gradual improvement in the extraocular movement. And she was mechanically ventilated for a duration of 95 days, and she was sequentially weaned from mechanical invasive ventilation to non-invasive ventilation and to room air by 22nd of February. So while recovering, she was on nasogastric tube. She was conscious, alert, and interested in surroundings. She had emotional ability, and vision and hearing were normal, and there was restricted extraocular movements in all directions, which was gradually improving. And left eye divergence width was predominantly noted, and right element facial palsy was noted, and there was deviation of tongue to the left side, and her gag was weak, and power wise, her axial power was recovering, and upper limbs proximal power was 1/5, and distally she was not able to move, and lower limbs was 0/5. Deep tendon reflexes was starting to become exaggerated, and ankles were still absent. Plantars were bilaterally absent. So at discharge, she had a modified Rankin score of 5. That is, she could only communicate by gestures, and she was having severe disability. She was incontinent and had only head control. So this is the last follow-up with her. So this is her recent photograph done 2 days back. So we can see that she's still on NG tube, and she has the right element facial palsy, and she's able to communicate now, and with power of definitely greater than 3/5 she has in the upper limb. And also in the lower limb power was also greater than 3/5. So the final diagnosis based on the clinical and radiological profile of this patient and the classical MRI picture, which shows bilateral thalamic lesions with a trilaminar sign on the ADC mapping. This was a case of recurrent acute necrotizing encephalopathy of childhood, and the antecedent infectious trigger was COVID-19 infection. So in view of recurrent, and when we went to the previous imaging also, the child had thalamic lesions, which was not very typical at that time. So this was a suspecting recurrent ANF. A whole exome sequencing was sent, which revealed a variant of uncertain significance in exon 12 of RANBP2 gene, causing cytosine to thymidine replacement in 1754 codon position, which was inherited in the heterozygous autosomal dominant state. There was also another mutation which was detected. However, parental validation is still awaited. The mitochondrial genome sequencing revealed no pathogenic variants. So coming to the
Dr. Narmadam, just Dr. Ramesh, would you like to comment?
No, ma'am. I think we're very well presented. Only thing was just the sequence of presentation. At least for the sake of discussion, probably you should bring in the imaging little later, like you present the case. You present the history, differentials, examination, the history including past history without going into the details of investigations, and then discuss your differentials. Otherwise, very well presented. Only in the localization, only question I had was encephalopathy. You said cortical localization. So are there any localizations for encephalopathy other than cortex?
Brainstem reticular activating system also is involved in the
Brainstem involvement, and or in other words, which areas of the brain when involved, they can have very severe encephalopathy or coma, you can say. Right? GCS was very poor for this child.
the involvement of the medulla and the thalamus can cause severe encephalopathy.
Thalamic involvement can cause very severe encephalopathy, brainstem obviously, and if it is cortex, it has to be very extensive cortical involvement. So always looking at other symptoms and signs, you need to see which of these areas is most likely. Right? So here there were some signs of brainstem involvement and some symptoms, right? The feeding, swallowing difficulty was there, some cranial nerve palsies. So you would localize it to brainstem plus minus thalamus in a severely comatose child with those symptoms and signs. That's all. Otherwise, it very well presented.
Arbadam, there were no seizures?
She had seizures, ma'am, both during the present and I mean this time she didn't have seizures. Prior the first presentation she had seizures, multiple episodes of seizures. This time only drop in sensorium.
Okay, proceed.
So coming to the discussion, so this is in 1995, Dr. Mitsubishi et al. He published this landmark article on acute necrotizing encephalopathy of childhood, and based on what his publications and findings, the diagnostic criteria of acute necrotizing encephalopathy has been made, and the criteria include acute encephalopathy following viral disease with seizures and deterioration of consciousness, absence of CSF pleocytosis, and protein may be however increased, and symmetric multifocal brain lesions involving bilateral thalami, upper brainstem tegmentum, periventricular white matter, internal capsule, putamen, and cerebellum, and elevation in serum aminotransferase levels have also been in the criteria, and we need to exclude similar disorders, including clinical differential diagnosis such as toxic shock syndrome, hemolytic uremic syndrome, Rey syndrome, hemorrhagic shock and encephalopathy, and heat stroke. And the radiological differentials that need to be excluded are late encephalopathy, glutaric aciduria, methylmalonic acidemia, infantile bilateral striatal necrosis, Wernicke's encephalopathy, carbon monoxide poisoning, acute hemorrhagic leukoencephalitis, arterial or venous infarct, severe hypoxic or traumatic injury. So, in one of our patients published from our institute by Utamam and Anam, this was a child who had acute necrotizing encephalopathy of childhood following infection with H1N1. So this is a typical neuroimaging characteristic. There is bilateral swollen and hyperintense thalami, and there is diffusion restriction and a classical trilaminar pattern on the ADC mapping, which shows a central area of necrosis or bleed, which is hyperintense on the ADC map, and surrounding cytotoxic edema, which as we know is hypointense on ADC, and surrounded by vasogenic edema, which is hyperintense on the ADC map. On SWA, there is blooming in bilateral thalami, and this is a post-contrast T1 image, which does not reveal any contrast enhancement. And there are also areas of diffusion restriction involving the medial temporal lobe and the dorsal pons. And the corresponding areas are also showing T2 hyperintensity, and also in the vermis we are able to see some hyperintensity. So this imaging pattern should clinch the diagnosis of acute necrotizing encephalopathy. So coming to the pathophysiology, so the common infectious triggers include influenza A and B and H1N1, parainfluenza, varicella, HHV6 and 7, enterovirus and reoviral strains, rotavirus, herpes simplex virus, rubella, Coxsackie A9, and measles and DPT vaccination also with wholesale components can be triggered. And this occurs in patients who have exaggerated immune response to various viral infections. So what happens is that a cytokine storm happens, causing massive release of interleukin 6, TNF alpha, interleukin 10, 15, interleukin beta, soluble TNF receptor, and interferon gamma. So this cytokine storm results in a systemic inflammatory response syndrome causing liver dysfunction, which causes the increase in the transaminase levels, acute kidney injury, shock, and disseminated intravascular coagulation. And brain injury occurs through alteration of the vessel wall permeability without actual vessel wall disruption. So this IL-6 and TNF alpha are actually critical for in this pathophysiology. IL-6 is neurotoxic at high concentration, and TNF alpha can cause damage to the endothelium of the central nervous system. So ultimately, this hypercytokainemia will engender proteolytic destruction of the blood-brain barrier through action of trypsin and the activation of matrix metalloprotease 9. So this increases the vascular permeability and it causes brain edema, petechial hemorrhage, and necrosis. So this is the sporadic ANX that we usually see. So this is another landmark article published by Dr. Nielsen et al., who found that patients who have recurrent ANX or familial ANX have a genetic predisposition. So this has been classified as ANE1, and familial or recurrent forms of ANE1 require at least one of these criteria, additional criteria, which is in addition to the Mitsubishi criteria. So a relative with a confirmed AME and relative with history of unexplained CNS dysfunction occurring in the context of concurrent febrile illness or recent infection or recurrence of AME in the proband. And RANBP2 is the gene that is implicated in this recurrent AME, and this is a 358 kilodalton protein located on the cytoplasmic surface of the nuclear core, and it has numerous roles throughout the cell cycle. In the nuclear, during the interphase, this nuclear envelope associated functions, which include facilitation of protein import and export and thermoylation of protein cargoes. Basically, thermoylation is a post-translational modification of the protein, and hence it is necessary for proper protein function. And in certain cell types, including neurons, it has been detected associated with microtubules and mitochondria, which suggests roles in intracellular trafficking or energy maintenance. And during mitosis, nuclear envelope breakdown occurs, and it localizes to the kinetophore, where it facilitates histochromatid resolution and in the formation of the spindles during the mitosis. So coming to the management strategy, we know that often we treat this with intravenous glucocorticoids, including methylprednisolone and dexamethasone. Also, immunoglobulins and plasmapheresis have been used. And there have been reports that suggest that in spite of the severity of presentation and late administration of steroids, good outcome was still found, and therefore some researchers suggested that a trial of steroids should be given to all patients with AME. Therapeutic hypothermia is another method of anti-cytokine therapy, especially if it is initiated within 12 hours after onset of disease. And this is another recently published article in 2022 in Pediatric Neurology. Because the main cytokine that is implicated in ANX is interleukin 6, early use of tocilizumab was tried in 3 patients who were aged 5, 8, and 10 years with severe ANE, and these patients were given both intravenous methylprednisolone and tocilizumab at 18 to 32 hours of encephalopathy in addition to supportive medical therapy. So all these patients had recovered. 2 patients had recovered significantly. The other patient was left with some sequelae. So the patients who improved significantly, the MRI findings have been shown here. So there was T2 hyperintensity and bilateral thalamic on day 1, which had resolved on day 5 with small T2 right-sided thalamic hyperintensity still persisting, and also dorsal falls hyperintensity was present, which had decreased in size on day 5. In patient 2, there was diffuse pontine hyperintensity and bilateral thalamic hyperintensity, which after 2 months, when the scan was repeated, there was no sequelae left. So coming to the outcome, so basically there are some good outcome predictors and poor outcome predictors. So age above 4 years and asymmetric unilateral thalamic involvement and reversion of the image post treatment are signs of good outcome. And poor outcome predictors include below 1 year age, and serum aminotransferase and protein elevation in the CSF are poor outcome indicators. And presence of hemorrhage and localized tissue loss, which is necrosis on MRI, and delirious behavior, which usually results from brainstem lesions, all of them are poor outcome predictors. So in this article by Wang et al., they had tried to give a MRI score based to assess the severity and prognosis of the ANE. So the presence of hemorrhage, cavitation, location of lesions including the brainstem and white matter. So each of them, hemorrhage, calcification, brainstem, cavitation, brainstem and white matter were awarded 1 point. And the patients having the highest MR scores were in the poor outcome category, whereas the patients with lower MR scores, 1 or 2 had better outcome, 3 or 4 had poor outcome. And this is another the incidence of full recovery, mild to moderate sequelae, severe sequelae, and death was noted to be in the order of 12.8%, 23%, 33.3%, and 28.2% respectively, as noted in this study by Basu Keta. In our own institute, we had done a study on the clinical profile of children with acute necrotizing encephalopathy. And we had recruited, this was a retrospective chart review from January 2015 to December 2019. And so in these patients, we were able to, totally we had 24 patients, including children and adolescents aging from 6 months to 18 years. And we tried to analyze the antecedent viral trigger. And in that, out of 24 patients, 21 were tested for the cause of viral prodrome. And among those 21 patients, dengue serology was positive in 8, and the PCR for influenza was positive. Influenza A is in 10 patients, and influenza B in 3 patients were positive. And we also tried to assess the outcome by means of Glasgow Outcome Scale pediatric extended pediatric version. So based on that, we found that the mean dose of dengue precipitated ANA was higher than that of the influenza precipitated ANA. And the difference was, however, not statistically significant. And also 6 patients were tested for exome study, 2 of whom had recurrent ANA. And although both the patients had RAN52 mutation positive. So the implication of this study is that because high degree of influenza and dengue infection is precipitated in AMX, mass vaccination strategies for influenza and better hygienic measures to control dengue may reduce the incidence of acute necrotizing encephalopathy. One more significant finding in our patient was that she had cord lesions. Commonly, cord lesions have not been described. However, the first description of acute necrotizing encephalopathy with spinal cord involvement was done by Wing et al. And in a 2-year-old girl who had typical clinical manifestations of acute necrotizing encephalopathy, brain MRI revealed the classical pattern of bilateral thalamic and periventricular white matter changes. And cord involvement in the dorsal spinal cord, there was some hyperintensity on dorsal spinal cord, and which revealed that there was a cord involvement in acute necrotizing encephalopathy. So this was a sporadic case. Also, there is in 2013, later one more article was published saying that a 36-year-old female presented with acute quadriplegia, and she was having a typical findings, MRI brain findings suggestive of AMS, and she also had the presentation of an acute transverse myelitis, and she also her cord lesions were also typically present. I mean, a holocord lesion. Like longitudinally extensive transverse myelitis was noted. So this suggests that cord lesions could also be possible both in sporadic ANE and also in ANE1, which is a familial disorder. So this particular patient was evaluated with genetic sequencing, and she was found to have autosomal dominant missense mutation in the RANBP2 gene, which is predisposing for ANE. And also gene segregation was confirmed in other family members, and who had been affected with other episodes of steroid responsive encephalopathy.
Can you summarize the points, and then we are running short of time? Sangeeta?
Yes, Narmadam. Yeah, she's almost reached the last of her slides. Yeah. Come, go ahead, Narmadam, and conclude.
Yeah, so this was our patient H, who had this mutation. In our study, which we had done, we also found another girl who had the same mutation. And this is a case report by Dr. Vishal Sangikar and friends. So here again, there was a child with a recurrent ANE with the same mutation. So this suggests that a possibility of in the South Asian population, there could be a particular gene which can be implicated in ANF, but however, this requires further considerations. So, as a take-home message, we need to know that active necrotizing encephalopathy of childhood should be a differential in any child presenting with rapid progressive encephalopathy following a febrile illness, and typical MRI brain characteristics will aid in early diagnosis, and early identification and treatment can ensure better outcomes. And recurrent or familial ANF should raise the suspicion of RANBP2 related mutations, and yearly influenza vaccination and dengue control measures can be used as preventive measures. And ANF would be considered as a differential in the workup of encephalopathy with longitudinally extensive transverse myelin.
Thank you, Narmadam, for that excellent presentation. Actually, both the presenters had done a great job. Dr. Ramesh, any concluding remarks with regard to the presentations?
No, ma'am. Both one very well worked up and very well presented. I think together both the cases. What we need to remember is, other than infections, there are a lot of other conditions, especially immune-mediated and inflammatory-mediated conditions, many of which we are yet to understand the mechanisms and the treatment. As the title for this session suggests, always think beyond infections. Thank you.
There are
over to you, Sangeeta and Dr. Mini.
Yeah, there are no more questions in the chat box. Most of it has been answered in the presentation by Dr. Sushma and Narmadam. So,
Sangeeta, in Q&A, someone has posted this one. If no improvement in,
okay.
I think that's for the first case, I guess, in Bickerstaff encephalitis. If there is no improvement with first dose IVIG, should we consider second dose, and after how many days? And do you consider plasmapheresis also? When do you consider that?
You want to take up this question? Or?
No, any of you.
Yeah, so if you see the literature regarding the usage of second dose of IVIG, so we generally consider patients with GBS when there is a definite treatment related fluctuation, we consider the second dose of IVIG. Or if the patient has been treated with the first dose of IVIG and if there is no adequate signs of recovery even at the end of the 2 weeks, then for practical purposes, we are administering the second dose of IVIG also. So we have never utilized plasmapheresis after IVIG in any of our patients so far. Do you have any experience in using plasmapheresis after IVIG in any of your patients, Dr. Ramesh?
No, most of them, as you mentioned, typically we wait for 10 to 14 days after the first IVIG. If they don't respond, we do use a second course of IVIG. I think if the question is specifically about Bickerstaff encephalitis, luckily 2 cases that we managed both responded to first course of IVIG. Although it was very slow improvement, but we knew once we have antibody positivity, most of them do well. Unless there are some ICU related complications, ventilation related complications, they do come out.
Yeah, I think there are no more questions. Over to Dr. Mani.
Well presented, Dr. Sushma and Dr. Narmadam. Thank you for presenting very interesting cases and reviewing the literature and approach to the cases. And thanks to Dr. Ramesh Kanangi and Dr. Maya Thomas for the excellent discussion on the localization, how to prioritize the differential diagnosis and the practical approach to the diagnosis and management. And thank you, Sangeeta, for moderating the session and bringing cases with the learning points. Thanks to all the attendees for the interactive participation. I forgot to mention that we will be having our Wednesday series once in 2 weeks from now onwards. And we'll meet again on April 20th with the advanced series lecture for the pediatric neurologists. Good night.
Thank you.
Thank you.
Thank you. Bye, everyone.